I'm Dr. Frieder from PRISM for Moms. It's so nice to see you. Today we are going to talk about premenstrual dysphoric disorder. And before we start, usually we talk about cases at the end, but I have a case that I want to talk when we start. But also I wanted to know what's your experience with it. Can be personal, it can be a patient or any difficulties treating it or recognizing it, or if you don't know about it, that's okay too. So if anyone wants to share anything about PMDD, we can talk about premenstrual symptoms. You know, I think we can talk about that a lot. So
sure, I'll go.
Okay, Bri.
I'm excited for this one because I don't know a whole lot, honestly, as much about this as the rest. But man, those hormones can really hijack your mood. And I think even just like as a parent now, every once in a while, I'm like the dragon comes out, and then I'm like, oh, that was now I'm having my visitor again. Okay. And so it's interesting. And I think, you know, I have a couple of preteens, and I'm just kind of starting to wonder how it'll go. But yeah, I don't know a lot about this. So I'm really, thanks for bringing us information on it.
Yeah, I'm kind of to piggyback off Bri. I'm kind of in the same boat. Like I know about it, I've heard about it, but I was hoping just to get more information.
Perfect. Yes. And Adriana said, I'm familiar, but don't know much. Good. You know, I think research has been around, but it's more and more in the topic. And there are a lot of things that are not known really about it, but we'll talk about it. You know, we'll talk and we'll make sense of it. So let me share my screen. Okay, can you see my screen? Perfect. Okay, good. So as I said, we'll talk about premenstrual dysphoric disorder. And I'll start by talking one of my cases that I wanted to share with you so you can have an idea of what I'm talking about, and let's see if it brings some thoughts. So this is a 38-year-old woman. She's a mother of 4 children. Her youngest is 8 months old. She has a history of depression and anxiety around her menses, with 2 suicidal attempts as a teenager. And when she describes her symptoms, she says that she has anxiety, that suddenly before her period, she doesn't know very well when, but some days before, she starts having anxiety, depression, feels giving up, on edge, hopeless, irritable, difficulty concentrating. She also has physical symptoms, including breast tenderness, and she has suicidal ideation, you know, and she said that since her kids are alive, she doesn't do it, she doesn't act on her thoughts, but they are very strong, the suicidal ideation. And she doesn't have any medical history that she can say about, or no substance abuse. But there are in the family, there are other women that have similar symptoms around the period. So that's my case. And I wanted to see if it brings up any thoughts on anyone, if you will want to know more about it, or what will you ask this woman?
I guess I'm curious with maybe like the why behind it, like the specific, like what are the hormone fluctuations, like week to week or day to day that contribute to it, just to be able to understand it better, to be able to explain it to the client better.
Yeah. What she said is also that during the pregnancy, she didn't have any symptoms. And this started after she started getting her period, you know? So yeah, it's kind of what you are talking about, the fluctuations in hormones, and we'll talk about that. So let me go to my next slide. So there are what we call premenstrual mood syndromes. That is a group, like 3 categories, and here you have them. But these can having symptoms before your period that are not that are undesirable. It can happen in up to 90% of women. So it's a lot of women. But it only occurs in women who experience a menstrual cycle. So who ovulate and who have a complete menstrual cycle. And symptoms can be mild to severe. And it is classified in 3, and we'll go over these 3 different categories. One is premenstrual syndrome, that you see the most in people. Then there is premenstrual exacerbation of a prior or of an underlying disease, that it can be depression, anxiety, bipolar, OCD. And then there is premenstrual dysphoric disorder that we'll talk more about that. It's very interesting because premenstrual syndrome has a genetic component up to 95%, you know, and I was reading that twins that are identical twins have more concordance of having it between the twins than twins that are not identical. So that makes us think that there is a big genetic component in this syndrome. The other thing I wanted to say before I continue is that you need to think now these days, you need to think about it in different situations. So and also in the past, you know, like a woman that has an hysterectomy, but they didn't take away her ovaries, can have PMS because they are ovulating, you know? So that's one thing. The other thing is what happened with transgender males, you know, before getting their gender affirming therapy or after, because sometimes there is a delay between starting testosterone and the stop of the menstrual period. And some people may continue to ovulate. So you need to be mindful about this syndrome because it's very, very common. So the most common one is premenstrual syndrome. And the definition that the ACOG give about it, the American College of Obstetricians and Gynecologists, is that the patient must have at least one symptom during the 5 days pre-menses in each of 3 previous cycles. And symptoms must be relieved within 4 days of onset of menses without recurrence until day 13 of the cycle. So they basically need to have symptoms before they get their period, the symptoms get better with the period, and then they need to have like several days without any symptoms. And the symptoms need to be present in the absence of pharmacological treatment, any hormones use, or drug or alcohol use. And this what some researchers agree and don't agree. Most people say that premenstrual syndrome, you are usually not affected by, you know, yeah, you are feeling maybe sick or not great, but you can still function. The ACOG says that you need to have some kind of functional impairment in social, academic, or work performance. At least in one area of your life, this needs to be affecting. And what are the physical, the affective symptoms you can have? You can have depression, anger, irritability, anxiety, confusion, social withdrawal, physical symptoms, breast tenderness, abdominal bloating, headaches, swelling of extremities, joint or muscle pain, and weight gain. And you can have either both emotional and physical symptoms, or you can just have one of them. So that's the most common one that you will see, is the premenstrual syndrome that most women have. Then there is the premenstrual exacerbation. And what is that? That's when a woman has depression, anxiety, bipolar disorder, any psychiatric illness that gets worse before their menstrual period. This hasn't been well studied, and we'll talk more about the relationship with bipolar disorder. But what you see is before the period, during the last phase of the cycle, you see worsening of their typical symptoms that they usually have. And this is very, very common. You know, you see it a lot, that women will tell you, I have depression for a long time, but it really gets worse before of my period. The important thing about it is that if the symptoms have the same quality as they have during their, let's say, depression, during their psychiatric illness, most likely it's an exacerbation of the psychiatric illness. If the symptoms are totally different, that make us think of something else, you know, maybe PMDD. Usually symptoms are worse premenstrual. And then we have what we are going to talk today is about premenstrual dysphoric disorder. This is not as common, you know, so the prevalence is up to 8%. What are the risk factors for it? Having a family history, being Caucasian, having a high BMI, having what we call metabolic syndrome. There are some changes in your body in terms of like where is your fat surrounded, you know, in your belly, and like having high cholesterol, high glucose, that can have an effect. Also high potassium diet, smoking, and lower education status. There seems to be, this was very interesting, there seems to be a correlation with history of trauma and increased risk of PMS or PMDD. Doesn't have to be PTSD, although there is also an association with PTSD. But just having a history of trauma can increase the risk of PMS or PMDD. And how do you make the diagnosis? And we'll review all the diagnosis, what you need for that. But to make the diagnosis, you need to ask the woman to do prospective rating of the symptoms of at least 2 consecutive menstrual cycles, which means, and I'll show you, you will give them, or you will tell them to use a calendar or a specific tool that are for this, and they need to write down every day for 2 months what are her symptoms, and at the same time, they need to write where are they in their cycle. So if they're menstruating, they're spotting, or what's going on in their cycle. And then when you look at it, you'll know when are their symptoms. So that's to make the diagnosis. A lot of time, we don't wait 2 months to start treatment, because you can imagine telling a woman that is very depressed, I'm going to wait 2 months because I need to make sure what's your diagnosis. It's a little bit hard. So what we do, we give a provisional diagnosis, and then we still tell them to check their symptoms and write it down in a calendar or in one of the scales that are out there, and then you revise the diagnosis. There are increased rates of suicidal attempts with premenstrual dysphoric disorder, and it's more common in women with bipolar disorder than in the general population. And it seems to be a correlation between the two, because bipolar disorder is also more common in women with PMDD than in the general population. So both situations are very common. So if you let it be and you don't treat these women, the rate of remission is very low, you know? And what I said before, it doesn't occur in somebody that doesn't have ovulation. So women need to ovulate to have PMDD. For some, it starts in adolescence. For some, it starts later in life. And it can get worse during the perimenopausal transition. And it's very highly comorbid with major depression, bipolar disorder, anxiety disorders, nicotine and alcohol use, and bulimia nerviosa. This is very important. So that you will have a patient with one of these disorders and you will think, what is this? This is part of their disorder or is PMDD? So again, if the symptoms are the same, let's say a woman comes with bipolar disorder and before her period, she gets hypomanic or she gets more depressed, you will think, yes. And that's how she usually gets her symptoms. That's most likely an exacerbation of her bipolar disorder. But if the symptoms are totally different of what usually happens to her, let's say she's more anxious or she feels confused, she has physical symptoms that she usually don't have, all that makes us think more about PMDD. So PMDD requires to have a careful psychiatric, gynecological, and medical history. You really want to make sure there's nothing else. Because remember, some people will come with a lot of physical symptoms, some people not. So you need to rule out medical issues. You need to rule out thyroid issues. You need to rule out endometriosis. And you need to rule out other psychiatric illnesses. So you need a very careful evaluation. As I said, symptoms always begin in the luteal phase, so after ovulation, and remit in the follicular phase after the menses start. And what is the reason for this? And this is what you were asking, Megan. So initially they thought, oh, maybe it's because they have more hormones or less hormones. And then they realized that, first of all, we don't know very well what's going on. But what we know is that these people have an individual response to the normal fluctuations levels of sex hormones. So they have like a heightened response. The symptoms are precipitated by these normal fluctuations levels. So it's not that they have higher levels or lower levels, it's just that they have a sensitivity to the normal variations of sex hormones during the cycle. There are some theories, because we will see later on how you treat it. You can treat it with antidepressants that act on serotonin. So there are some thoughts and some studies that says that having lower levels of serotonin can put you at risk of this. And there are studies that show in PMDD having lower serotoninergic function before the menses compared to people that don't have PMDD. There is also another thing called allopregnolone that is it's a metabolite of progesterone. So the progesterone gets metabolized into allopregnolone. And we don't know very well why or what happens, but it seems that exposure or withdrawal to it may contribute to PMS, PMDD in some women. So as you see, there are different reasons to this happening and different ways. So these are just different ways of treating it. Can it be treated with hormones? Can it be treated with serotonin agents, And we'll talk about that. So this is one of the scales that you use. It's called the Daily Record of Severity of Problems. And it's a tracker for the premenstrual symptoms. You can find it online. So what you tell them to do 2 of these, one for each month, for 2 consecutive months. And here you have all the different symptoms that happen during PMDD. And the woman needs to write every day if they have that symptoms and what's the intensity of the symptoms from 1 to 6, 6 being extreme. And also on the top, she needs to write what day it is. And also she needs to write if she's spotting or if she's menstruating. So then you will have it all in a scale. You can see when the symptoms are. And this scale is validated to use in this. There are some scales, there are some apps online or in the cell phones that you can use, but those are not validated. This is validated. So this will help you to make the diagnosis. And here I wrote what the diagnosis is. So you can see how complicated the diagnosis is of PMDD. So what you need to have in the most of the menstrual cycles, at least 5 symptoms must be present in the final week before the onset of menses. Start to improve within a few days after the onset of menses and become minimal or absent in the week post-menses. And what are the symptoms that you need to have? So one or more of the following symptoms must be present. That's category B. So you need to have affective lability, like mood dysregulation, irritability or anger, depressed mood, feeling of hopelessness, self-deprecating thoughts, marked anxiety, tension, or feeling of being keyed up or on edge. Those are, you need to have one or more of these symptoms. And then you need to have one or more of the following symptoms. And in total, you need to have 5 symptoms. So decreased interest in usual activities, subjective difficulty in concentration, lethargy, fatigue, marked changes in appetite. It's very common to have food cravings, often for highly sweet foods, hypersomnia or insomnia, a sense of being overwhelmed or being out of control. And then one of these symptoms is physical symptoms. So you also need to have physical symptoms. Breast tenderness or swelling, joint or muscle pain, sensation of bloating or weight gain. And these symptoms must be present for most menstrual cycles that occurred in the last year. And the diagnosis continues. So criterion D is symptoms are associated with clinical significant distress or interference with work, school, usual social activities, or relationship with others. This is very important. The woman needs to be affected by it in some level of her functioning. The disturbance is not merely an exacerbation of the symptoms of another disorder or personality disorder, and you need to confirm it by prospective daily ratings during at least 2 symptomatic cycles. And it's not the effect of another disease or of substance abuse. So as you see, it's very complex, you know, like women can have depression, anxiety, mood dysregulation, irritability, physical symptoms. They very difficult to function for them. And so what do? You know, how do you help them? Remember that first, you are going to start, you will make a diagnosis the day they come to you, but you are not sure if that's the diagnosis. So you'll tell them you need to check. If you don't have any scales, you can tell them get a calendar, write down your mood every day and write down when you get your period and how long it lasts, and then you will be able to make the diagnosis. But first, it's very important to educate the woman, to let them understand what it is, because people don't understand about it, and people think it's all on their head sometimes, you know, and it's not. It's a real thing that is happening and need to be treated. There are some studies that suggest that decreasing caffeine, salt, alcohol during the premenstrual week helps, also improving sleep, exercising, and telling the woman why it's important to educate them, because you can tell them, you know, if you know you're having a hard time, maybe the week before of your menses, you want to take away some stressors if you can, you know, maybe not have such a heavy week at work if you can decide that, or maybe do things to pamper yourself that week, you know? So making it easier on the woman is very important. There are some studies that just suggest that cognitive behavioral therapy is helpful. There are some studies that suggest that mindfulness-based stress reduction is helpful, and acupuncture has been helpful. So what happens with treatment in terms of medications, you know? So as I said, it seems to be medications that act on serotonin seems to have a good effect, you know? And so the SSRIs are the first line treatment, the antidepressants. And these are fluoxetine, paroxetine, escitalopram, sertraline, citalopram. Then there are the SNRIs that also work on norepinephrine, and they are also effective, like venlafaxine and duloxetine. All these medications that I wrote here, there are studies done about them, and they are they seem to have a good effect. What happens with how you dose it, you know? With SSRIs, you can tell the woman to take it either every day of the month, you know, or take it during the 2 weeks premenstrual period, or take it when the symptoms start. And there are studies that suggest that the three of these have a good outcome, you know, and it's important to think about it differently than what you think about an antidepressant for depression. You know that an antidepressant for depression will take 2, 3 weeks, 4 weeks to act. This is different. The effect is immediate, you know, so in the next few days, you know, so because the reason for it is different than the reason for a common depressive episode, there is information that these medications act faster in PMDD than what they will act in a depressive disorder. So for some women that maybe they have side effects of the medication, or they don't like to take medication every day, they know when their period will come, so they can plan it in advance, or they can take it when the symptoms start. That's very helpful for them, and they don't take it every day. Megan, you have a question?
Yeah, I was just wondering, like how does the body know that it's different, so that the SSRI would be effective for a PMDD, but for someone who, you know, has like a major depressive disorder, it takes several weeks?
Because the reason for PMDD, the cause, it's different for what the cause is for a depressive episode, a common depressive episode, you know. Here the hormones are related, you know, and there is a lot of interconnection between hormones, neurotransmitters, and we know that like this SSRIs help with serotonin, but that can help with GABA also, and that can help with prolactin, you know, like, so there is all associated. So that's one thing. The other thing is that the progesterone, you know, and the metabolite that it's called allopregnanolone, you know, that can also have an effect, you know, and that also interrelated. And there are, you know, there are some medications that act there directly. So there is a lot of research on the area. There are new medications actually now, because either antidepressants are effective, but they are not 100% effective. Not everyone will get better with it. So they are doing new research on it to see who will get better and who will not, and how to treat them, you know? And that's when we see that there are different medications for some reason tend to work, you know, in a different way. So there is a lot that is not really known about why, really, but I think the best way of explaining is that the reason for the PMDD is a different reason than the depression. You know, depression is not caused by the fluctuation levels of hormones in the menstrual cycle. And PMDD is caused by that. So that's why certain medications work more than others, you know. The other medications that work is that SNRIs that are venlafaxine and duloxetine, but
Ariella, can I ask you a question?
Yeah,
real
yeah,
quick?
yes.
Hey, okay, so just to make sure I heard you right, because that's fascinating. So a person with PM, is there any side effects? Is there any downside? It's almost like feels like taking ibuprofen if you have cramps. Like if you're starting to feel the rage or like these symptoms come up, you could maybe pop a Lexapro, and that wouldn't maybe. Is there
But
any
it's,
side
you
effects
know, you
to
need
that?
to take it for a few days. it's not that you take a Lexapro and immediately it will act, you know, like you need to take it, let's say for 5 days or 6 days before your period, you know, or 7 days, the amount of days you have the symptoms.
And is there any is there side effects to that?
Yeah, the
Like-
side effects are the side effects of the medication.
Okay.
So yeah, that's why some people will decide I want to take it just during my symptoms.
Sure.
And some people will decide, no, you know, I don't remember when I have my period and everything. I just want to take it all the month because I don't have side effects, you know?
Interesting. Okay.
And what is very interesting is that there is no withdrawal with the SSRIs. So you
Yeah,
can take
question
it.
of withdrawal. Yeah.
Yeah. So
Okay.
there's no with SSRIs in PMDD. There is with the SNRIs like Effexor, venlafaxine. So they don't recommend to use venlafaxine like just the 2 weeks premenses or during the symptoms. They tell if you're going to give venlafaxine, you should give it the whole month. But yeah, this is fascinating, you know, because there is so much we don't really know. We know that because these medications started working, and some studies suggest that they work in lower doses, you know, so you don't need the higher doses you use for other things to treat PMDD. So the interesting thing also is that fluoxetine, that is Prozac, has been in the market to use for PMDD for many years. And because women didn't want to take it for a medication called Prozac, because Prozac is for depression, they changed the name to use it for PMDD. So let me see, I don't remember the name now, but you can look it up. It's a different name for, supposedly, you can choose, you know? Let's see. Sarafen. Sarafen is the name to use for, that they put a different name for PMDD. So this is one of the treatments. And then this is first line treatment because it has a response, it has less side effects, it's not so harmful as other treatments can be. And I'll show you why I'm saying that. The other treatment is oral contraceptive, is hormones, you know? So in terms of hormones, studies show that oral contraceptives don't seem to be so great for it. But if you are going to use one, the ones that have drospirenone are the ones that have more effect. And why? Because this drospirenone comes from a different variation of the progestogen, and it's associated to spironolactone that I wrote here downstairs. And it helps with physical symptoms. So Jazz and Jasmine have drospirenone, so they seem to be more effective. But the reality is that even oral contraceptives are not so effective. They also see that in studies, they show that, you know how you take your contraceptives and then you have a few days that you take placebo, that they don't have any hormones. If you can diminish the amount of days, that's why they think this Jazz and Jasmine help, because it's just 4 days of the non-medicated pills, you know, the pills that don't have hormones. So the least amount of days without hormone is better. They saw that women, that the best way to treat it, one of the ways is to put a woman into menopause. But that has a lot of side effects and risks, you know, so we don't do it usually. But they saw that if you want to treat somebody with hormones and put them on the state of menopause, that's very helpful for this. So here I wrote, so in other situations, this is not to use as first line for sure, you know, in treatment-resistant women, you might use the gonadotropin-releasing hormones agonists that are leuprolide and goserelin, that they create a menopausal stage. And this has a lot of serious side effects like osteoporosis, cardiovascular disease. So you will try not to use it unless you need to use it for a short period of time until you decide what treatment. But I would say that this needs to be managed by a specialist. Like it's not something that you can start like, Then danazol is also a hormonal medication that inhibits ovulation. And then you have spironolactone that is good for the physical symptoms. It's a diuretic, it's a potassium sparing diuretic, and it's good for physical symptoms. And we'll talk a little bit more about this, but the other things you can do and have been shown to be effective. One is using calcium, and that has a small effect. There are shown inconsistent findings with magnesium and vitamin B6. There is a lot of evidence to use chasteberry. It's a herbal treatment, and it seems to be helpful. So sometimes you might want to associate it with SSRIs if you are using that. And then surgery, that's the last resort. You don't want to take away the ovaries of a woman that is a young woman because of all the negative consequences it can have. But theoretically, it can help, but there's not much data supporting it. So 40% of women do not respond fully to the SSRIs or the contraceptives. That's reality. And there are no studies done. What do you do with these women that don't respond to anything? The other thing is that you have to be careful in women with bipolar disorder and PMDD. Because if you give them the antidepressants, they can get into a manic episode or a mixed episode. So there's not much data how to treat women with bipolar disorder and PMDD. So there are two options, really. One, the current recommendation is to give the mood stabilizer and give the contraceptive. The other possibility is to give the mood stabilizer, and if they are stable from their bipolar disorder, start very carefully the antidepressant and keep an eye on them, So that's a possibility too. Bray, do you want to say something?
I was just curious, is like a heavy menses a symptom of PMDD sometimes? Is like heavy bleeding correlated with the mood stuff?
So it's not really recognized as one of the symptoms, but some people complain about it. If somebody comes with heavy menses, I would recommend checking for something else to, to rule out other things. But cramping can be, it doesn't have to be the heavy menses, but it can be cramping, a lot of pain that can be associated. Either way, you need to do it.
Contraceptives might be first line treatment for that, but not first line for the
mood symptoms.
Psychiatrics. Okay. Thank you.
So if somebody comes, and tells you, I have PM, you make the diagnosis, they have PMDD, but at the same time, you hear that they want to use a contraceptive because they want not to get pregnant, you might try as first line treatment, a contraceptive, if they don't have contraindications to it, But if you really want to try what will work best, the antidepressants work best for you. So it's very complicated because we don't know enough about the treatments and how to help these women, but these women really suffer, And there is a lot of women that either have an underlying psychiatric disorder and also have PMDD, or they have a worsening of their psychiatric disorder premenses. So you need to see what's the situation of each woman. What I do with women that have a worsening of their psychiatric illness, I usually tell them to increase their antidepressant the days before their period. So if they, let's say, take Zoloft 50 milligrams, I tell them, okay, increase it to 75. 10 days prior to your menses. And that seems to help a lot. It's kind of based on the same idea that it will help in a different way and during that period of time. For some reason, it wasn't helping before, that you increase it, but I noticed it really helped to increase it before their menses. And there is new research now. One thing that I realized is that it's really the fluctuation on hormones that seems to be affecting women. Because if you put them in a menopausal state and there's no fluctuation of hormones, or if you give them some hormones to make them stable, let's say estrogens will be the same every day, progesterones will be the same every day, there is no change in their hormones, those women don't get it. If you add to those women, let's say a little bit more progesterone or estrogen, they start having it. So it's really related to the fluctuations of hormones. The thing is that we don't understand very well how to treat that, like without such invasive or having the side effects that some of the hormones can have. That's why with the contraceptives, they have more effect if you give them less days of placebo, if you give them more days of hormones, but still you need women to bleed, that's good for the uterus, and every now and then. And yes, I noticed that patient that I mentioned at the beginning, at some point they put her on these contraceptives that you take for 3 months and bleed after a 3 months period, and that seemed to help her a little bit with the PMDD. Then she tried in the past Zoloft, and she tried Paxil and didn't seem to work so much. So I put her on desvenlafaxine or Pristic. That is an SNRI, but still works on serotonin. And I like it because you don't have the withdrawal that you have with venlafaxine if you were to take it. So that's what I did, and she seemed to get help from it. But the problem is, like, what do you do in the situations where there's no help, with medications or women with bipolar disorder that you don't feel comfortable giving them an antidepressant. Any questions, any thoughts? Or I wanted to open a discussion about it, so we can talk more and I can answer questions because it's a complicated subject, But there is more research now. I wouldn't say a lot of research, but there is more research now about it. And as you see, it's so common to have premenstrual symptoms, maybe not PMDD, but to have mood symptoms around your period. So that I see it a lot. Like women that tell me, oh, my symptoms get worse before my period, and that seems to be so common and so debilitating because they tell I can't sleep, I get irritable, like I have this rage that I don't understand why. It's so good when do
you see a difference in like symptoms worsening like after having kids or even before having, like they improve after having kids? Does that make a difference?
That's a great question. I was reading about it, and some people suggest that after having kids, it can get worse. Some studies say no, that it's usually the same after adolescence, but I hear it a lot. That symptoms get worse after having kids, and as I said, it gets worse in the menopausal time, perimenopausal, before menopause. because your hormones are so all over the place that time, and it makes sense. You know, hormones are fluctuating so much that it gets worse during that time.
Interesting. Yeah, I've seen that too. Just curious.
Yeah, yeah. Any other questions? Any thoughts about it? I think the important message is that it can get to be severe, you know. Women want to die sometimes with it, you know. So even if they know, like some women tell me, you know, just the education is helpful, because when they know it will pass, that gives them some relief. But some women actually feel so bad that they try to hurt themselves. So recognizing it, knowing that it exists, you know, that it's a real diagnosis, and that there are ways of treating it, it's also important. And there's so much we don't know. Why the relationship with bipolar disorder, why it's so common in women with bipolar disorder, why women with PMDD are at more risk of having bipolar also. You know, like we don't understand so well, but they are both cyclical, you know, cyclical. And so it's a lot to learn more about it, but I think we are at a stage that we can treat it and we can help women that have it. But very important to rule out other things, you know, to know that it's not something physical. So I would say first time you see somebody with it, you send them to the OBGYN. If needed, you send them to the primary doctor, you know, and make sure it's nothing else that you are seeing.
Do you feel like primary care doctors and OBs have a pretty good awareness of this and would be like quick to diagnose, or is there not that much awareness?
I think OBs should be, you know, like this is something that they should know, it's in their area. And also, you know, like usually if a woman has an OBGYN and I want them to start a contraceptive, I send them to the OBGYN, you know, and they tend to know about it. I think the primary doctors should know too, you know. Maybe not as good as the OBGYNs, you know. But I sometimes I prescribe the contraceptives if I need to, you know, because like I have patients that really get better with it. So I had prescribed if I feel it's somebody low risk, you know, for any adverse effect of the contraceptives. Yeah, because I have some patients that actually do better on both, you know, on the antidepressant and the contraceptive. But it's very interesting because now there are new studies that talk about medications that work in that hormone, the allopregnanolone, you know, that is a metabolite of progesterone. And it's like, it's not so clear how they work and why they work, you know, but it seems to work. And there are some studies that suggest that allopregnanolone at lower doses can make you more anxious, but at higher doses, it's calming because it acts on GABA. So there is so much to know about, you know, there is so much unclear why, but we know that all these hormones and neurotransmitters are interconnected, you know, that we know. But that scale, I think it's really good to have it on hand, you know, to make the diagnosis. It's the daily record of severity of problems scale. And some people will tell you, I want to use my phone, you know, and I found an app, and that as long as they can keep an eye on their symptoms and when is their period, and they can give you an accurate description of what's happening, like if you can see it, that they were tracking it during 2 months, that's very helpful. Any questions? Any thoughts? So it used to be not even recognized before, like not recognized in the DSM, you know, now it's part of the DSM since the DSM-5, you know, so before it was one of the depression diagnosis and like a research one, you know, now they put a different entity for it.
I imagine it's quite powerful for people to realize this isn't their personality.
Totally. Because there is so much involved, you know, in terms of being a woman and having the symptoms suddenly. And yeah, that's part of who you are when you get your period, you know. Yeah, it's true. So that's what I said, that education about it is so important, because that can alleviate. Some people tell me, you know, at least I know it will go away, you know, like it's not something to stay. And next time I know what to do to make it better if I can, you know?
Mm-hmm. I guess I have like my thoughts is like, has this just been a problem of all time, or like PMADS, is this on the rise, like because of stress and whatever nutritional deficiencies or whatever, you know, is this like another one of those on the rise that we could maybe someday see, or is this just life and now there's a way to make it better? We don't have
That's
the
interesting. Yeah. I don't know about the past, but I know that when they do studies worldwide, they see it. It's not cultural, you know, like some no, some diagnoses have a cultural pattern, you know, and this doesn't. You see it in all over the world, you know.
You said one of the risk factors was being Caucasian. Do you know how that plays into it?
I know that I don't know how it plays on it, but I know that in studies that compared demographics, you know, they see that Caucasians have more than Black women. It's also the same with low socioeconomic status, you know, like how that plays a role, or low education status, you know, how that plays a role, you know. It might be because the diet is not so good for some people, you know, and that makes them more at risk, because I wrote it down, there are some things that are helpful in terms of lowering the risk. Where did I write it? So diet high in iron, zinc, thiamine, and riboflavin lower the risk of PMS. So some studies suggest, you know, so there might be a diet component to it with vitamins and that. But I hope it was helpful to hear about this.
Thank you.
Sure.
Yeah, thank you, Dr. Fritter.
Sure, we are going to meet in 2 weeks to make up of the time I wasn't available in December. We are going to talk about infertility. So, and the psychological components of it. So that will be on the 25th, no, Carrie?
Please tell your friends. I'll also send out a reminder on the Monday before that.
Good. Thank you.